Thanks to everyone who sent in such great questions. We have really an absolutely incredible list of questions for this year's webinar. We do this every year. We often do a couple of webinars in the year, but we always do this Hair Loss Awareness Month webinar. And the questions that come in are always fabulous and allow us to have a discussion about some topics like no other discussion. And so I want to thank everyone for sending in these incredible questions. This will be recorded. These questions will be posted. May take a few days or weeks, depending on how long we take to get it uploaded. But before we start, I do want to mention that hair loss is surprisingly complex. It is deceivingly complex. And at first go, it does appear that hair loss is rather simple. But the reality is that hair loss is certainly much more complex than we give credit to, and much more complex than much of the general public is aware. And so I say that because this webinar is for educational purposes. And if you have hair loss, you really ought to review your full story with a hair loss specialist and allow them to examine your scalp. Nothing beats the ability to have an incredible story about your hair loss from the day you were born up until the present day. Yes, sometimes what happened when you were 4, 6, 8, 10, 12, 15 matters to your hair loss story. Absolutely. And then to examine your scalp, eyebrows, eyelashes, body hair, nails, skin. Does something happening on my nails matter to my hair loss diagnosis? Of course. Does whether or not I have hair on my arms matter to my hair loss diagnosis? Of course. And so all these things matter. And then there are several diagnostic tests that can be helpful. Now, they're not always needed to make the diagnosis, but sometimes they are. There are some autoimmune panels which can be very helpful, some levels of iron and thyroid which can be relevant. They don't often change the diagnosis, but they influence the treatment plan. And so there are about 65 to 70 blood tests that can be ordered. We generally order 3 or 5 or 10 in any given patient, but there's another 45 waiting. And so an incredible complex array of tests that are waiting. So that is just a reminder that to diagnose hair loss, we need a good story. We need to examine the scalp, and we need to review tests. And so if I don't have a good story and I can't examine the scalp and I haven't seen any test results, then by definition, you are quite limited in your ability to offer diagnosis. So we're going to divide today's questions, or my team has divided today's questions in androgenic hair loss, alopecia areata, scarring, and I think those are the groups. And so we're going to take a look at these questions together. I don't know how many questions we'll get to. There have been years which we have gone on for a long, long time on these webinars. Today I am somewhat limited in the end time, so I hope we get to all the questions, but if we don't, that's okay. But I will be watching the clock in hopes that we can, because these are such wonderful questions that have come in. So let's talk first about androgenetic hair loss. Androgenetic hair loss is one of the most common types of hair loss in men and women. And in women, it often causes hair loss in the central scalp. And when you look up close, the hairs become thinner. We call that miniaturization. And so let's take a look at some questions that have come in from androgenetic hair loss. When you start the treatment for androgenetic hair loss with Minoxidil, a very popular topical treatment, do you start with formulations containing propylene glycol, like liquid solutions? And if there are some issues like irritation, do you then switch to formulations without propylene glycol? Or do you always start with Minoxidil without propylene glycol? It's a wonderful question. And so the answer is it doesn't matter. Both are equivalent. My preference is to start with a minoxidil solution or foam product that does not contain propylene glycol, simply because it's so much better tolerated. And so the famous foam, which goes by Rogaine foam, as well as the new generic foams that are available, the foams lack propylene glycol, and you can sometimes get minoxidil made up by a compounding pharmacy that lacks propylene glycol. But the propylene glycol containing solutions and then the non-propylene glycol containing solutions are equally effective. And so it really doesn't matter whether you use a propylene glycol containing minoxidil or a non-propylene glycol containing minoxidil. They're equally equivalent. You're best to start with a propylene glycol free minoxidil. It's just so much better tolerated. And that's why the minoxidil foam has become so popular. And so there are patients that prefer minoxidil drops. Those are the solution formulations that have propylene glycol in them. Some patients just find that I can get it much more accurately in my scalp if I use the drops. And those contain propylene glycol often, but some people aren't irritated by them and they're just fine. So it comes down to a little bit of what the patient prefers. But if you're trying to decide what to start with from day one, these propylene glycol free solutions are probably better. Another great questions come in asking, is it reasonable to start minoxidil smaller dosages, like 2% once a day, or 5%, but less amount, like half a mil, in order to get less amount of initial hair shedding for psychological reasons? As many of you are aware, minoxidil causes hair shedding in many people when you start. That's not really all that unique to minoxidil. Minoxidil often gets blamed for it, but if you start an anti-androgen, you often get shedding. If you start low-level laser, you often get shedding. PRP is notorious for shedding, even though it's underreported in the literature and people don't talk about it. PRP is a dramatic shedder of hair. So anything that stimulates hair growth in androgenetic hair loss has the potential to cause shedding. I don't think that starting lower doses is the way to go. So I don't start 2% instead of 5, or little drops instead of a lot of drops. I just go for it. And the reason is that if you're going to shed, you're going to shed. And unusual or atypical dosing or fancy dosing strategies to try to stop the shedding usually don't dramatically change shedding patterns. And in many cases, these atypical dosing schedules just prolong shedding. So if you go from 2 drops for a week, and then 4 drops for a week, and then 8 drops for 2 weeks, and then 15 drops for 12 weeks, and then 25 drops for 2 months, instead of the patient shedding for 2 months, the patient sheds for 6 months. And so I think if you're going to use minoxidil, use it, provided you understand the risks and the benefits. Use the recommended doses to start. And certainly if you tolerate it really well, you may be able to increase your dose slightly in months ahead beyond the standard doses. But starting with the approved doses first for a number of months is important. And be aware of the possibility of shedding. Shedding occurs in a lot of people, and it's not a reason to stop. For the vast majority of people, the shedding improves after 2 or 3 months. It doesn't improve in every single human being, but it improves in a lot of people. And so I very much appreciated this question. I don't start with low doses. I go for it. Question 3 applies to androgenetic hair loss. Another wonderful question asking, I have a lot of young female clients who come to consultations with their mothers, and their mothers are concerned about the hair density, which has changed. They say that in childhood, the daughter's hair was good, and now they have shedding, and the density is less. On trichoscopy, it doesn't look like androgenetic hair loss. I explain that it's due to hormonal changes, but what is the right explanation? I mean, when does the hair set up for women? We can't compare the density in childhood and a grown adult. It's such a great question because the default diagnosis for hair loss in women is androgenic hair loss. And so as soon as someone comes through the door, and I'm looking at a door right now, as soon as someone comes through the door, I am thinking to myself immediately, this person has androgenic hair loss. It's my responsibility to disprove my theory, but this person has androgenic hair loss. I have to rule it out. That's my job. And so some women present with, my hair isn't as thick as it used to be. What do you think? It's androgenic hair loss. Yeah, but when you examine the scalp, you don't see a lot of miniaturization. It doesn't look like what I've seen in balding in women and doesn't look like it. It's androgenic hair loss. It just happens to be early androgenic hair loss. The earliest stages of androgenic hair loss are associated with a reduction in density. You may not see dramatic miniaturization yet. If you're, good at trichoscopy and you enjoy measuring hairs, maybe you might catch some subtle differences. If you biopsy, you might catch some subtle differences, but you might not. But you see a lot of single hairs. Normally, hairs are grouped in bundles of 2 and 3s. Hairs come out of the little pores in groups of 2 and 3, 4, sometimes 1, but a lot of 2s and 3s. In androgenic hair loss, those bundle architectures break down. So you get hairs emerging in bundles of 1 and 2 instead of 2 and 3. They may not be miniaturized yet, but the bundle architecture is changing. And some women have a little bit of increased shedding. And so I often hear it's, said in patients that come in for consultation that, I'm shedding a bit. I have a telogen effluvium and I need your help. And the vast majority of patients don't have a telogen effluvium. They have androgenic hair loss. And so telogen effluvium is overdiagnosed and androgenic hair loss is underdiagnosed in our world. And so this is such a wonderful question because it highlights the early stages of androgenic hair loss, where you get this subtle, slow change in density. Hair is not like it used to be. Now, some of these individuals could have a telogen effluvium as well, and a proportion have telogen effluvium as the exclusive diagnosis, but a large proportion of these patients have androgenic hair loss. And by comparing the amount of hair in the front, by comparing the part width in the front to the amount of hair in the back, sometimes you can appreciate that the front is thinner. Sometimes a biopsy will capture the androgenic hair loss if you're really, really not sure. But photographs will also capture it over time. Take a photo. It's so early that you can see a patient back in 6 months. Listen, we're not doing any treatment right now. I've taken 82 photos. I put them in your chart. Let's see you back in 6 months or 9 months. Let's see what happens. And if you do use trichoscopy, you can also take up close photos and even measurements if your devices allow you to do that. So this is a very typical picture of what androgenic hair loss does. Androgenic hair loss causes hairs to become thinner. You can see that this hair is so much thinner than this hair. But in the early stages, this is what androgenic hair loss does. You normally have bundles of hair in groups of 3, 1, 2, 3, 1, 2, 3. They're all coming out of the single pore. But what happens in androgenic hair loss is they come out by themselves. Come out by themselves. Look at this one over here, all by itself. That's very typical of androgenic hair loss. But you can see the caliber of these hairs is not that thin. They're all kind of the same caliber. But the architecture is altered. And that's what characterizes early androgenic hair loss. And so if you look at the part width, you may appreciate that the part width in the front is a little wider than the part width in the back. And a part width is what happens when you part the hair down the middle and look at the color of the scalp, whether it's lighter colored or darker colored, the part width is the amount of scalp that's showing. And in androgenic hair loss, the part width in the front or the top is wider than the part width in the back. Wonderful question. Thank you. How effective is scalp massage for androgenic hair loss or telogen effluvium? What's the best way to massage the scalp? You know, scalp massage is probably not completely useless, but it certainly isn't very effective. And there certainly isn't a lot of evidence to support its use. Scalp massage does have a subtle hint that it could do something. So I'm not willing to discard it as completely without benefit. But it really is important to understand that scalp massage has very little evidence of being helpful in the treatment of hair loss. Yes, I know it's popular, but popularity of a treatment has no bearing whatsoever on whether it's useful or not. So that's an important principle in hair loss. I really don't care very much if a treatment is popular or not popular. What matters is how effective is the treatment. And scalp massage is not well studied. It's unlikely to have a tremendous amount of benefit, despite its popularity. And so when you look at typical protocols for treating hair loss, and this slide shows a typical treatment protocol for female pattern hair loss or female androgenetic hair loss, where we have the most effective treatments outlined at the top. These are called first-line treatments. These are the treatments we might reach for first. Second-line treatments are treatments that we might reach for second if the first-line treatments don't work. Now, some patients don't want the first-line treatment, so we might start the second-line treatments right away. And then the third-line treatments are treatments that, you know, they have very poor evidence. They may help a little bit, they may not help that much, but we generally don't start with them. And so you might start a third-line treatment if the first-line and second-line treatments don't work. And this particular slide shows treatments for premenopausal women, so women prior to menopause. And you can see that scalp massage is nowhere on this list. And so if you poll hair experts from around the world, you name the country, bring them on board, scalp massage will be rated very poorly by hair loss specialists around the world. And so not a typical treatment that is used in the common management of hair loss. But I realize it's very popular. Question number 5, is microneedling a good option for androgenetic hair loss or telogen effluvium? So microneedling is this technique where little needles are either rolled onto the scalp in a rolling pin type apparatus or pressed onto the scalp in a little apparatus or machine that allows little injuries to take place on the scalp. And that's called microneedling. Micro meaning small, and needling referring to the needle. So little needling. And the size of the needles differs from little tiny needles, 0.25 millimeters in size, right up to 1.5 or 2 millimeters in size. And in the year 2024, which we're in now, the world of hair loss research cannot agree in any way, shape, or form what size microneedling is best. And every time a study comes out saying it's a 0.6, another study comes out saying, no, you have it wrong, it's a 1.2. And then another study comes out and says, no, you've got it absolutely backwards, it's a 1.5. So microneedling is in the early days. I think there's some evidence that microneedling is useful, so it deserves to be on a list of treatments. But the evidence for microneedling still is quite poor, and it would be incorrect to place microneedling in the category of first-line treatments, which generally have a lot of good evidence that have been studied for years and years and years. But nevertheless, microneedling is a third-line option in my practice, and microneedling is often combined with minoxidil. the microneedling of the scalp once a week or once every 10 days might improve the efficacy of minoxidil. And that's been something that's been known for about 15 years, dating back to some original studies by an author by the name of Durat. And you can look up those studies should you be interested in. But those studies showed that if you use minoxidil with microneedling, you get better results than if you use just minoxidil alone. Now, as is common in many of these treatments, whether microneedling or PRP or certain other treatments, a lot of the side effects are poorly documented. And so you won't find in the medical literature much that can go wrong with microneedling. Do microneedling all you want. It's a wonderful treatment. It works wonderfully. The reality is that some people get tremendous shedding with microneedling. Some people get breakage of hair with microneedling. Some people get folliculitis with microneedling. Some people have a very sensitive scalp and cannot do microneedling. So microneedling is not for everyone, but it certainly is something that I do recommend from time to time. And generally, we'll start with a 1 millimeter microneedling size as a default and go from there either up or down. But I do think it has enough evidence that it finds its way onto my list of truly effective treatments in the management of hair loss. And it has its best evidence in androgenic hair loss. I'm not a fan of using microneedling in scarring alopecia. Doesn't mean it can't be used, but I'm certainly not a fan of it because sometimes injury to the scalp flares scarring alopecia. I do use microneedling sometimes in alopecia areata, and sometimes the microneedling in alopecia areata with clobetasol or with minoxidil can be highly effective. And so it's useful in alopecia areata as well. Question 6, does inversion or hanging upside down help bring blood flow into the scalp, and does it help grow hair? There's not a lot of evidence for inversion therapy. I know it's a very popular treatment to consider, and many people talk about it, but there's not actually a lot of evidence. And androgenic hair loss is in part due to some changes in blood flow, but that's not the main issue. The main issue is a sensitivity to androgens, at least in males and to some degree in females as well, and some chemical changes that occur at the level of the hair follicle that are causing this miniaturization of hair, essentially a death of hair in a very limited manner, but you do get a reduction in the size of certain hair cells. You get a progressive miniaturization of the hair because hairs are going to sleep. And these changes are not helped by bringing blood flow into the scalp. If androgens are going to cause hair loss, you can imagine that bringing more blood flow into the scalp just brings more androgens into the scalp and helps the process more. So there would be just as much reason to believe that bringing blood into the scalp would help as there would be reason to believe that bringing blood into the scalp would be detrimental. So it's certainly not a treatment that has any evidence of being helpful. And so it's not something that I recommend at all. And it's not something you will ever find in treatment protocols from experts in hair loss. Let's take a look at a couple of general questions that have come in. These are all, again, really wonderful questions, and I thank everyone for sending them in. They're a series of questions like no others, and I really enjoy joining you for these webinars. The questions that are asked are just incredible and really allow us to approach these subjects in such a helpful way for so many. Question number 7. I've used topical minoxidil for the last 2 years, and as of 7 months ago, I started taking 2.5 milligrams of oral minoxidil as well. At some point, do I need to stop the topical, or is it okay doing both? And so the short answer is it's okay to do both. The long answer is it might not be okay to do both. And the longer answer is, it's possible you're wasting your money, but let's take a look at these. So again, to really answer this question fully, I need a full story. What's happened in your life and your hair from the day you were born up until today. Surgeries, medications, illnesses, the whole thing. What your scalp looks like. What your eyebrows look like, eyelashes look like, body hair, nails. And what your blood tests look like. All these influence my answer. But here we have a question. I'm using topical minoxidil. Now I'm using oral minoxidil for 7 months. Should I be stopping the topical or just continuing everything? So provided there's no side effects, it's certainly reasonable to continue both. And there's many, many people in the world that continue both, and hundreds of patients in my practice that are on both. As we dive deeper into this question, let me mention that 2.5 milligrams is a great dose for some women. And it's much, 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 much too high of a dose for other women. So anyone listening should not be of the opinion that, okay, let me grab a pen. Oral minoxidil dose in women is 2.5. Not correct. 2.5 in some women 0.6, in some women 0.25, in some women 1.25. My personal preference is to start with 1.25 and go from there, sometimes even 0.625. Once you start getting beyond a milligram or 1.25, you are increasing your chances of side effects with each microgram that you go up. 1.25 is pretty well tolerated. 1.5 is pretty well tolerated. 1.75 will get you a lot of phone calls to the office saying, my feet are swollen. It's still not super common, but you'll get the calls to the office. 1.875 will get more calls. 2 and 2.5 will get more calls. And not only swollen feet, but as you go up on the dose, the phone calls come in saying, I'm getting to be a little bit too hairy. What should I do? Hair on my face? Sometimes hair on the body. Fortunately, other issues like dizziness and headaches, insomnia or sleeping issues are pretty uncommon, but these are side effects as well. And many of the side effects of minoxidil are dose dependent. And so as you challenge the dose from 1.25 to 1.5 to 1.75 to 2 to 2.5, your chances of hair growth goes up. Your chances of nice results goes up, but your chances of side effects goes up too. So a word about the 2.5. Now, there are lots of patients that use both topical and oral. There is a little bit of research that suggests that women that use topical and oral have no better results than people that just use oral. It's only one study in the androgenic alopecia telogen effluvium literature. But it's interesting. It's a small study. It is of limited conclusions, but nevertheless, it's intriguing because what it suggests that if you're on oral minoxidil to begin with, adding topical minoxidil may or may not help you. What the study does not say is anything to help this particular question. In other words, what we don't know is if you're on topical minoxidil and you're on oral minoxidil, should you just take away your topical minoxidil and throw it in the garbage and move on with life and use the oral minoxidil? We do not know that. There will be some people, likely, that by stopping the topical minoxidil, they'll experience hair loss. And so that study needs to be done. But it certainly is intriguing, this particular study from New York, suggesting that Um, you know, maybe in patients that are using both oral and topical, the topical is really not adding that much. Now, it depends a little bit on the dose. If you're using 2.5 milligrams of oral minoxidil, I would agree that probably the topical is not doing much. Hard to say. We need the studies, but probably not doing much. But if you're on 0.25 milligrams of oral minoxidil and you're using Rogaine twice a day, yeah, I think a topical is doing something. So don't get rid of it. So I think that's important to be aware of. Question number 8. We know that we have a lower hair density in the temples, but sometimes patients complain that the temples are always shorter. So I wonder, is the right explanation that it could be a different anagen phase in different durations of the scalp? If we don't see miniaturization, or there are no other things which could influence this condition. So I think that the anagen phase is different in the temples. The temples is an area of the scalp which has much shorter hair, this region in here. And that particular region of the scalp has shorter hairs, reflecting its shorter anagen phase. So the length of the anagen phase influences the length of the hair. And I think the temples is a very special area of the scalp which has a shorter anagen phase. And we don't understand all the reasons for that. But in women that don't have hair loss, the remainder of the areas of the scalp have a pretty similar anagen phase. In androgenic hair loss, the anagen phase starts dramatically changing so that women with androgenetic hair loss cannot grow as long of hair down the back. They need to cut their hair shorter at the back. The hair does not grow as long because of a reduced anagen phase. But the temples are special because the temples have a reduced anagen phase. And we need more research to understand this, but I think that's pretty well accepted that there are some regions of the scalp that have these subtle differences. Question 9. Question 9 is a very unique question. I thank the individual for sending this in. It is a question that for physicians and trichologists who are on the call or will view this at a later date, there's a lot of wonderful things that can be learned from this particular question. So let's get to it. I'm enclosing 3 trichoscopy images at 1-month intervals. Let me pull this down. Showing the before and afters of the same region of the scalp, just behind the hairline, somewhere in here. The hair in this region is predominantly transplanted hair, so the individual had a hair transplant. Can you tell if scarring is taking place? That's the question. The hair that is circled, which I'll show you in a minute, was not growing over several months since its emergence from the scalp, and it stayed the same length prior to disappearing. The hair labeled 12 appears to have gone, leaving the mark that is shown. What is this mark? We'll take a look together in a minute. The hair reappeared 1 month later. In this location, only beta-methazone valerate, a steroid, has been applied infrequently to calm down inflammation. The hair labeled number 11 appears to be growing normally. The scaling appears to be recurring at the same location, and scaling occurs when using beta-methazone valerate. So let's take a look at some up-close images, which we call trichoscopy. So this individual has sent in 3 trichoscopy images 1 month apart. And these are hairs that we're told are transplanted in the scalp. And the individual has said, here's what the scalp looks like in June. We see this little hair here. And then in July, it disappears. Where'd it go? And then in August, it's not there. And so we are asked what is hit number 11 and number 12. So number 12, this hair here, disappears. And this is a follicular opening. This is what hairs look like when the hair follicle falls out. There's another hair underneath, usually waiting to grow, and then it grows. So if this truly is 1 month apart, this is pretty robust regrowth. This is pretty significant growth of hair in a month compared to the last image. So as we're thinking about this question, is this scarring? The first thing to mention before we begin is what's missing. And what's missing is a story, a chance to examine the whole scalp and tests. But what's really missing is the story. And so to diagnose hair loss, I need a story. Where was the transplant? Why was the transplant? How many grafts were done? What's the patient's health? What's been used? How much betamethasone is used? What was used before? What's used now? I need a story. So generally 50 to 75 questions I need the answer to. And if I don't have those 75 questions, the answers to those 75 questions, I'm generally not super happy. I can certainly offer a lot of insight into things, but I need the answers to these questions. That's the magic of hair loss, is that when you put all of these answers to these questions in the bucket, oh, I got that answer, put it in there. Oh, I got that answer, put it in there. When you put all this together, you can get these wonderful diagnoses. And that's why AI and artificial intelligence will be very helpful in hair loss, because it does that we as humans think isn't important, that we as humans neglect, that we as humans think, why would I have to ask that? It's irrelevant. Well, it's relevant, and AI will do that for us. But the thing that's so important here in this question is, wow, is this scalp ever happy? This hair here in 1 month is very, very happy. It has grown a significant amount in just a short period of time. And I think that's really important. This is the hairs in June. This is what the hair looks like in July. It fell out. And here's what the hair looked like in August. And a scarring alopecia doesn't usually do that. Now, I can't say for sure this isn't a scarring alopecia because I don't have enough information. But what I can tell you is this scalp's happy. These hairs are happy. Scarring alopecia does not do this usually. So we're gaining insight into what's happening. If you plant some flowers in your flower garden, and a month later you come back because you've been on holidays for a month, and you come back and you find that, wow, this garden is beautiful. Look at how it's growing. You don't have to ask yourself, are these flowers sick? You don't have to ask yourself, is there a fungus in the soil that's destroying things? You don't have to ask yourself, is there some major problem? This is so important. So let's take a look at some of these baby hairs. Let's take a look at this area over here on the right side of the scalp. What you can see is that 1 month later, we've got a baby hair emerging. Pretty hard to grow baby hairs if you have a scarring alopecia. Similarly, if you take a look at these baby hairs in June, 1 month later, you have the hair remaining. And 1 month after that, you have 2 hairs emerging from this particular area. So this particular scalp is quite happy to grow baby hairs. And there's nothing in particular that's suggesting that we have a lot of evidence for scarring alopecia. Now, it doesn't mean there's no evidence, and I'm going to come back to that in a minute. Look at these baby hairs. This is the baby hairs in June. This is the baby hair in July. And this is the baby hairs in August. 2 months goes by and these baby hairs are staying there. If you have a scarring alopecia affecting this area of the scalp with rip-roaring inflammation, those hairs aren't going to survive. And so these hairs that are growing, these hairs that are growing, these hairs that are growing very happily is certainly against the scarring alopecia. Now, the question is, what's with all this scale? Now, for someone new to trichoscopy, the immediate thought is, this is scarring alopecia. Look at the perifollicular scale. Look at the perifollicular scale. Look at the perifollicular scale. And it could be. But I think that is a amateur jump to the diagnosis. We don't make diagnoses based on one feature of the scalp. We put everything together. And this scalp, at least in these these images that are shown here, shows us that the scalp's able to grow some hairs pretty easily. Just in a month, it sprouts massive hair. It's a massive growth of hair. Now, when I do see this scaling, my feeling is, why in the world does the hair have this scaling? And there are many reasons why a hair can have perifollicular scale, or this little scale around it. It is true that scarring alopecia is one of the reasons, but it's not the only reason. And in transplanted scalp, what's important for our hair specialist attendees to be aware of is, in transplanted scalp, things look different. You are operating on a scalp that has had years and years and years of sun damage sometimes. You're operating on scalp that has been traumatized by the hair transplant. It's a big surgery. It's a bloody surgery. It's a big wound. And so things look different. And so you have to be careful not to jump to the same conclusions that you might on a non-transplanted scalp. But this certainly does not suggest scarring alopecia. But if any doubt exists, the simple answer is a biopsy. Now, the problem with doing biopsies is biopsies are not easy in transplanted scalp because they're scarring. They're scarring from the transplant. And so if you do a biopsy in an area of a hair transplant and send it off to the pathologist and say, let me see what he comes up with. Let me see if the pathologist can figure out what's going on. I'm not telling him anything. The pathologist is probably going to say, this is unusual. This is unusual. Scarring alopecia. Something real strange here. Look at all the scarring. But if you send it off to the pathologist saying, listen, this is a complex case. The patient had a transplant, and I'm seeing some interesting changes in the transplanted field, the pathologist will say, okay. Some of this scarring could be from the transplant surgery and the healing process. So I can't jump to too many conclusions too quickly. Thanks for that information. Yeah, I'm not seeing primary evidence of a scarring alopecia. So biopsies of hair transplants are tricky. And so if you have an open dialogue with your pathologist and say, listen, this is what happened. This is what I'm seeing. Please help me. You're going to get some really useful information. If you say to your pathologist, listen, I don't know who you are. I don't know where you work. I'm just shipping my biopsy off to you. What do you see? Scarring alopecia. So you have to be careful. But I don't see any great evidence of scarring alopecia here. I can't rule it out completely. But I would need to know more. It certainly is a very interesting question. The hairs that grow so quickly in such a short period of time is unusual for a scalp that has scarring alopecia. So let's take a look at question number 10, and then I think we'll take a short break, maybe after question 12. So the next question applies to steroids and steroid injections. Steroid injections are done for a variety of scalp issues, alopecia areata, scarring alopecia. These are, some of the more common reasons that steroid injections are done. The medication is generally called triamcinolone acetonide. A very popular brand is Kenalog, so you might hear it said, I'm going in for Kenalog injections. My doctor wants to do Kenalog injections. The actual medication is called triamcinolone acetonide. So the question here is, my question is about the strength or the dose of injectable Kenalog. I was diagnosed with Lichen Planopilaris, which is a scarring alopecia, and the dermatologist injected 10 milligrams per mil times 2 vials into my scalp. It was painful, and the soreness was prolonged. After the appointment, I educated myself and found out that 5 milligrams per mil and 3 milligrams per mil is recommended. So when I saw my dermatologist 7 weeks later, I asked for the lower strength, 3.3 milligrams per mil. I now have dents in my scalp. I'm scheduled to have more injections at the end of this month. It will be 9 weeks from my last visit. Should I have more steroid injections? What strength of triamcinolone do you use for LPP, for FFA? What interval do you recommend? How do you know if the injections are working? So it's really a wonderful question, and these questions pertaining to steroid injections are, hugely important, and I really appreciate this question. There's a number of principles which I'd like to highlight here, and that is when I use steroid injections, I always start with 2.5 milligrams per mil. I'm not opposed to going up to 5 milligrams per mil, but I always start with 2.5 milligrams per mil, and I never ever use 10 milligrams per mil in Lichen Planopilaris or alopecia areata. Some of my expert colleagues do. And so there's a little bit of personal preference here. 2.5 milligrams per mil hardly ever causes indentations. 5 milligrams per mil sometimes does, and 10 milligrams per mil often does. And so there's no getting away from that fact that as you increase the dose of Kenalog or triamcinolone acetonide, your chances of indentations goes up. But does it work better? Well, in alopecia areata, we know probably not. We know from some limited studies that doing injections with 2.5 milligrams per mil probably works fairly much as good as 5 milligrams per mil. So in alopecia areata, it's pretty clear you probably don't need to go up, at least initially. Keep it simple. Start 2.5 milligrams per mil. Now, some wonderful colleagues of mine around the world certainly use 5 and 10, and there's nothing wrong with that. That's just my personal view. I do not want my patient to have indentations if possible. Indentations improve over time. They come back to normal over time, provided further injections are not done into that indentation. But the chance of indentations with 5 milligrams per mil is around 3.3% in normal scalp or in alopecia areata. And with 10 milligrams per mil, it's 20%. So 1 in 5 patients that get 10 milligrams per mil are going to have indentations. That's a lot. And generally in a given day, I easily do 5 injections, 5 patients with injections. So that means one of them will go home and have an indentation. That would be very high odds. And so I always start with 2.5 milligrams per mil. So a tip or a pearl is that if you want to reduce the chances of indents, keep to 2.5 milligrams per mil or 5 milligrams per mil. My preference is 2.5 milligrams per mil. And the tip that I teach all of physicians and specialists that train with me is start 2.5. Keep it simple. People do not like to have indentations. And so I'm a big believer in that. The indentations will improve over time. And this diagram shows a cartoon of the skin. And you can imagine a steroid injections going in here, and you get this little crater or indent in the scalp. We call it atrophy. If you continue treatment, so you do another injection here, the indent gets worse. Sometimes it can take a long time to reduce an indent that has already been indented. So we do not want to inject into an indentation. But if you pause treatment, it will resolve. It may take 3 months. It may take 6 months. Usually it takes around 2 or 3, but it will improve. There is a little bit of theory that if we inject salt water into this indent and puff it up and stretch the skin, the salt water dissolves and leaves the skin within 25 seconds, but the skin is stretched and that stimulates collagen production. And so one way to help speed up the resolution of these indents is to inject salt water into them. And so here's a diagram that I believe in practice. This is a diagram that I created. And so if you notice atrophy on the scalp or a little indent, and there's only one or two of them, so the patient's been injected all over the scalp, but you just have two little indents, it's okay to keep injecting, but just avoid the indented areas. Inject other places. And consider reducing the steroid by half. So if you used 10, use 5 milligrams per mil. If you used 5 milligrams per mil, use 2.5. If you use 2.5, use 1.25. And then invite the patient back 6 to 8 weeks later. Is the indentation still there, those 1 to 2 little spots? If no, continue the injections. If the indent is still there, no more injections for at least another 8 weeks. Now, if the patient has 3 indents or 4 indents or 5 indents or 6 indents, we're not doing any more injections. I may put salt water in the indents to puff them up and stimulate resolution of these indents, and then I'll invite the patient back in 6 to 8 weeks. If the indents resolved, then we can go back to injecting again at half the dose. If we use 10, we use 5. If we use 5, we use 2.5. But if the indents haven't resolved, we're not doing any more injections for a while, and I may puff them up with saline again. So the short story is I'm never particularly worried about the indentations because I know they will resolve, but I take the indents seriously and I don't inject in areas that are indented. And it's a message from the scalp saying your dose is too strong. And so if I see indents, it's telling me, you thought 5 was a good dose? Well, you're wrong. It's 2.5. You thought 2.5 was a good dose? Well, you're wrong. It's 1.25 for me. And so I take the indentations seriously. And if I see indents, it's an indication to maybe pause. And so I don't like to inject in scalps that have a lot of indents. If there's 1 or 2, maybe we'll keep injecting and bypass the indents, but I don't like to do so. If steroid injections are going to be done, I like to inject every 6 to 12 weeks. For alopecia areata, I like to inject every 6. For scarring alopecia, 8, 10, 12, with the preference towards 12. Steroid injections have a lot of myths and misconceptions around them. They can be an extremely helpful treatment for so many people if done correctly. And by injecting every 6 weeks at the appropriate dose, you dramatically increase the safety of these treatments. For some patients with Lichen Planopilaris, there is no better treatment on the planet than steroid injections. Now, of course, there's only so much steroid injections we can do. You can't inject weekly or daily, but for some patients with Lichen Planopilaris, steroid injections are incredibly helpful. And so by having a rule in your mind that steroid injections are harmful and steroid injections cause problem, you really limit yourself from a potentially valuable treatment. Not everyone is highly responsive to steroid injections, but certainly a large proportion of people are highly responsive. FFA to some degree, but not as much as LPP. And other scarring alopecias can benefit from steroid injections, including Folliculitis Decalvans. Alopecia areata, of course, is incredibly helped by steroid injections. And patients with a patch or 2 of alopecia areata can regrow their hair in 80 or 90% of situations with steroid injections. And so I think that what's really important about steroid injections is understanding this technique very well, learning the risks and the benefits very well, learning how to monitor side effects very well, but keeping it in your toolbox because of how valuable it is. So take a look at a question about alopecia areata, and then we'll take a short break after this one. So alopecia areata is an autoimmune condition that is fairly common in the world. It's certainly not anywhere near as common as androgenic hair loss or telogen effluvium. But about 2% of the world will experience alopecia areata in their lifetime. And that compares to, maybe 1 in 5,000 people who will experience frontal fibrosing alopecia, 1 in 15,000 people who will experience folliculitis decalvans. So alopecia areata is not uncommon. Some patients develop patches of hair loss. Some patients develop very significant amounts of hair loss. Some people develop hair loss all over the scalp. We call that alopecia totalis or universalis. So the question that's come in is, do the new JAK inhibitors basically make the other treatments obsolete? So it's a really wonderful question. We now have 3 JAK inhibitors that have been approved for the treatment of alopecia areata. Baricitinib, ritlecitinib, and a new JAK inhibitor that was just approved last month, just about 3 weeks ago. These JAK inhibitors are approved for severe alopecia areata, meaning 50% or more hair loss. And that's really important to be aware of. They're not approved for patients with patches of hair loss. They're not approved for patients with limited amounts of hair loss. They're approved for patients with 50% hair loss or more. And so the question asks, do these new drugs make the other treatments obsolete? Well, the answer is no, they don't. And that's for a couple of reasons. First, these treatments are formally approved for severe alopecia areata. And most people with alopecia areata don't have severe hair loss. Most patients with alopecia areata have patches or several patches that come and go, sometimes come and go every few months, sometimes come and go every few years. That's the most common form of alopecia areata. And so these particular new drugs are only approved for severe alopecia areata. So we still need to understand the proper treatment for patchy alopecia areata or limited alopecia areata. And so for mild alopecia areata, someone that has a patch, the first line treatments are topical minoxidil, topical steroids, and steroid injections. And for 80% of people with patches of alopecia areata, there's only 3 treatments I need in my toolbox, and I can help them. And that's minoxidil, steroid injections, and topical steroids, especially clobetasol and betamethasone in children. So when we're talking about patches of alopecia areata, 24-year-old male who has a little circle of hair loss back here, JAK inhibitors are not even in the discussion. JAK inhibitors don't even come up in the meeting because this patient will benefit from a topical steroid or steroid injections or minoxidil or all 3. And often we do all 3. And of course, there's other second-line agents that can be helpful if the first-line agents don't work. And then there's other treatments that can be considered in the unusual circumstance that the first and second-line agents don't work. But for the vast majority of patients, hair can be improved with steroid injections, topical steroids, and topical minoxidil. It's the severe forms of alopecia areata that are treated with the JAK inhibitors, baricitinib, ritlecitinib, and the new JAK inhibitor as well. Now, there are other treatments that can be considered as well for severe alopecia areata. So even in severe alopecia areata, are the other treatments obsolete? No. I just started a patient on methotrexate for severe alopecia areata. Why not a JAK inhibitor? Well, because the insurance wouldn't cover it, and it was cost prohibitory. I just started a patient a week before on a 6-week course of prednisone. Why not a JAK inhibitor? Well, the patient has had a recent onset of alopecia areata. It's only been a few, months, and we're trying to shut it down quickly with the hopes that we can stop it and get the hair growing and then come off all treatments altogether. When you start a JAK inhibitor, the plan should be you're going to be on it for life. Now, some people can come off, that's true, but the plan should be you're on it for life. And so if you're thinking to yourself, this patient of mine has severe alopecia areata, but, I think they've lost it quickly. I think it's going to come back quickly. I think they're going to regrow their hair by the fall. Well, then a JAK inhibitor is not for them. And so many of these treatments that we've had in the toolbox before for severe alopecia areata are still there. Methotrexate, oral steroids, trials of difencyprone or squaric acid, which we call immunotherapy. These are still very much in the toolbox. And so the answer to this very nice question is, do the JAK inhibitors make these other treatments obsolete? Absolutely not. The JAK inhibitors provide a very valuable tool in the toolbox for managing severe alopecia areata. But the JAK inhibitors are not completely effective. The JAK inhibitors help about 50% of people with severe alopecia areata. They don't help everyone. So there'll be many people that gain no benefit from the JAK inhibitors. And so we still have a long way to go to have good treatments for severe alopecia areata, but certainly the JAK inhibitors are a wonderful step in the right direction. And certainly the JAK inhibitors provide useful treatments for a very significant proportion of people with severe alopecia areata. But they don't help everyone, and they don't help everyone with alopecia totalis and universalis. They help maybe 20% of patients with totalis and universalis, 20-25. So we need to understand all the tools in the toolbox in the year 2024, because the JAK inhibitors do not provide us with a treatment that is universally effective for all patients. And so absolutely, the other treatments are not obsolete, as the question goes. So thanks again to everyone for these great questions. These are absolutely intriguing questions that you ask, and I appreciate them all. We're going to talk about frontal fibrosing alopecia, then we'll talk about Lichen Planopilaris, and we'll talk about CCCA and Folliculitis Decalvans, and there may be more. It depends on what they've added to the list. So frontal fibrosing alopecia is a scarring alopecia that it gets its name from the fact that it affects the frontal scalp, but it also affects the area behind the scalp. It affects the eyebrows, eyelashes, body hair. It sometimes causes little papules or bumps on the face. And it's an autoimmune condition very closely related to Lichen Planopilaris. So we have a question that's come in asking, can you please share if there's any up-to-date data on the importance of avoiding titanium dioxide for someone that has FFA, frontal fibrosing alopecia? It's a very difficult ingredient to avoid, as it is in so many makeup and skincare products as well as sunscreen. So the short answer is we don't have any evidence. The longer answer is that in 2018 and 2019, titanium was the story in FFA. And this was the story. Titanium in sunscreens, titanium in everything. And the reality is that the evidence has not mounted to the point where we can convincingly say, yeah, this is a good story. The reality is that there's no convincing evidence that titanium really is a culprit. And so that's where we're at in 2024. So the theory is that titanium dioxide particles and nanoparticles get down in the hair shaft and they incite an autoimmune reaction, which we call a lichenoid reaction. And there's been evidence of finding titanium from sunscreen in hair follicles and in hair particles. And the theory is certainly good, but that's the theory. The reality is that there's insufficient evidence. And so, I'm not opposed in the year 2024 to a patient using a titanium dioxide sunscreen. I'm not, because there's insufficient evidence. If a patient really wants to make a dramatic change in their life, then let's talk about fragrances, and let's talk about some other allergens, and let's talk maybe about some organic fillers, organic products in sunscreens, rather than the mineral products, the titanium and the zinc. And so I'd much rather a patient use a titanium dioxide and a zinc oxide sunscreen and avoid the organic components with all the long names, And I would much rather a patient avoid fragrance and avoid preservatives as much as possible than engage in a discussion about titanium dioxide, titanium dioxide, titanium dioxide, because there's insufficient evidence. And so we don't have all of the story yet, that's for sure. It's an area that is, in need of more investigation. But I think if we're going to rely on science and we're going to trust in science, then we have to trust in science, and we have to put to rest things that don't have good evidence, or at least continue studying them and not make huge lifestyle modifications if we don't have great evidence. And so we do have little bits of evidence that suggests that certain allergens could be relevant, fragrance, some preservatives. And that's why if someone wants to make changes in FFA that could help them, go hypoallergenic. Buy a hypoallergenic shampoo, buy products that are as hypoallergenic as possible, avoiding fragrance and preservatives where possible. It doesn't help everyone, but it's a much better strategy for most people than focusing on titanium dioxide, titanium dioxide, titanium dioxide. Because the reality is women with FFA, most women, especially lighter skinned women, are at increased risk for skin cancer. And LPP, it's not clear if it's LPP or LPP and FFA, but this particular group of scarring alopecias come with an increased risk of squamous cell carcinoma skin cancer, basal cell carcinoma skin cancer, and melanoma. And so my belief is that based on that concept and based on the insufficient evidence, we need to protect ourselves from the sun, and we need to put the titanium dioxide to rest for now until there's better evidence. Can you please discuss the use of Accutane in the treatment of FFA? I've been taking 10 milligrams 3 times a week. It has helped, but I have extremely dry eyes. How long should people take it for? I've now reduced to twice a week to see if my eyes feel better. And so, again, this is a nice example of a piece of information where I need more information. So there are many reasons to have dry eyes. Accutane is one of them. The scarring alopecia itself contributes to dry eyes and meibomian gland dysfunction. So it's important to understand the timing of this. And other treatments that are commonly used for FFA, including finasteride and dutasteride, also cause dry eyes and various issues in the eye. And so this question is more complicated than it seems, because a person could be using Accutane and have dry eyes, but they're predisposed to that already from the FFA, and they're also on finasteride or dutasteride, which is also contributing to the dry eyes, and maybe even more than the Accutane. And so certainly Accutane does contribute to dry eyes, dry mouth, dry lips, and it's sometimes a dose-limiting issue. The doses we use in FFA are much less than in acne treatments. And you can see here 10 milligrams 3 times a week is a pretty common strategy. Sometimes we'd use it daily, sometimes more, but not uncommon to use it this frequency. Reducing the doses is quite reasonable. Sometimes in patients that really have dry eyes from Accutane, those little dose reductions from 3 to 2, don't make a huge difference, but it's worth doing. If you have the ability to see an optometrist or an eye specialist or even an ophthalmologist, it's worth it, because they have all these fancy abilities to test ocular function and look in the eyes and assess the meibomian glands and even assess lubrication and rule out other causes of dry eyes, which include what we call the Sika syndrome or Sjogren's-like syndrome, which can very rarely occur with conditions like this. So seeing an eye doctor really is very helpful. But again, more to the story sometimes than presented. And so for frontal fibrosing alopecia in 2024, you can see that isotretinoin is very valuable. So is finasteride and dutasteride. These are probably the two most effective treatments for frontal fibrosing alopecia. Now, these treatments aren't for everyone. Isotretinoin cannot be used in premenopausal women without use of contraception. Same with finasteride and dutasteride. Finasteride and dutasteride have their set of side effects. Isotretinoin has its set of side effects. So it's not right for everyone, but these are very important treatments to discuss because of how valuable they are in FFA and in FFA. How long should treatment be given? There's no magic number. And I think that, scarring alopecia is a challenging condition. And I think that many people, really do want there to be rules that, scarring alopecia burns out after 9 to 12 months. This drug you take for 6 months to 12 months, this drug you take for this long. We would like rules because it gives us some control over a disease that's challenging and feels like we don't have control. But that's wrong. That's false. And it's a concept that permeates the internet and permeates much of this, scarring alopecia community, but it's not correct. Some scarring alopecia, goes on for a long, long time. Some scarring alopecia is kept quiet by medications. But once those medications are stopped, the scarring alopecia comes back. And then there are some people that do have the scarring alopecia go to sleep and the medications can be stopped. But it generally takes longer than 1 year. And so this concept that scarring alopecia burns out after 1 year is incorrect. So in this particular question, how long would we need to use isotretinoin? It's not clear. I don't have enough information. Isotretinoin is one of those drugs that we're kind of adding up a little score sheet how long a patient's been on it. We don't want patients on isotretinoin for 30 years. Some drugs, we have this little time ticker. Isotretinoin is one of them. Cyclosporin is another one. Hydroxychloroquine or Plaquenil is another one. Prednisone, of course, is another one, although we don't use prednisone that often. But there are certain drugs that as soon as the day the patient goes on it, we're asking, when are they going to come off it? And Accutane is one of those. So, there's a limit. But at these tiny doses we use in FFA, that limit is stretched out to a large number of years. But it depends on the patient how long to use it. And for some patients, being on some treatments 1 year, 2 years, 5 years, 6 years is not uncommon at all. And so, many patients will say to me, I've been on these drugs for, 3 years already, and my scarring alopecia is not quiet yet. Is this unusual? And the answer is it's not unusual. We, of course, do win a great amount of the time, meaning that we do put scarring alopecia to sleep quite a large amount of time. But there are some challenging and stubborn cases of scarring alopecia where we need to add other medications. And there are some patients that can have mildly active disease even after 3 years. And so I think we have to be careful about these rules and broad statements that we so much would like to have. And so many of the diseases in our world have rules. When you have a certain cold or infection, you get a runny nose for 4 days and then it goes away, and then you get this for 2 days and then you're back to work. When you have food poisoning, you get you're sick to yourself for 2 days or 1 day, and then you're feeling better and you're back to work. And we want those rules with Lichen Planopilaris, frontal fibrosing alopecia, and Folliculitis Decalvans, and all the scarring alopecias. And it doesn't work that way. There's tremendous variability in these conditions. And one person can have one story. And when they share that with another patient, the patient says, well, that's unusual because that certainly isn't how mine works. And so there's quite a bit of variability. Now, when a patient is on clobetasol lotion once a week, we're not really feeling too anxious about the length of time they're on it. That particular dose has very good long-term safety, doesn't thin the skin, doesn't get absorbed, provided they're using, reasonable amount. But there are certain drugs where we're watching. We don't like patients to be on potent immunosuppressives for long periods of time if they don't have to. But it certainly isn't uncommon to be on hydroxychloroquine or methotrexate or mycophenolate mofetil or a JAK inhibitor for a year, 18 months. Those would be certainly not uncommon at all. Question 14. Is there any treatment that targets helping to prevent scarring alopecia around the ear area? I've completely lost my sideburns and the hair is thin around my ears. I'm also losing lots of lashes. Currently taking dutasteride 3 times a week and Accutane plus topical tacrolimus, tofacitinib, and minoxidil, all used twice a day, and red light therapy. Is there anything else that can be added? And so I think that, this is again one of those that we need the full story from start to finish. What is the age of the patient? What is the health of the patient? Does the patient have depression? Does the patient have weight issues? Does the patient have mood issues? Does the patient have osteoporosis? Does the patient have, you name it? Every little piece of information is relevant. The story matters. The story absolutely matters. And so when patients say, as in this question, what's next? What do I do next? The answer is, I don't know, because I don't know your story. In order to really help someone with hair loss, I need the story and a very detailed story. We need to examine the scalp. And then sometimes we need additional tests. So for frontal fibrosing alopecia, here is a very, very typical algorithm for first line, second line, and third line treatments. And so you can see that finasteride, dutasteride, isotretinoin are first line agents. And this individual is on dutasteride and isotretinoin. The individual is also on tacrolimus, minoxidil, and tofacitinib, topical tofacitinib. So the question is, what next? Well, the what next is, in my clinic, not super challenging because we follow a very logical, evidence-based approach. And so we ask ourselves, do we have any more first-line options to consider? Well, the patient's on isotretinoin, they're on dutasteride, they're on tacrolimus. Could consider steroid injections if they haven't been done before. Could consider hypoallergenic shampoos. Could consider purchasing a shampoo devoid of fragrance, devoid of allergens. And there's many of these, including Free and Clear, Vanicream Free and Clear being one example, Scene fragrance-free shampoo being another example. And there's several of them now. And if a person has used those, then we don't fret. We move down to the second line options. And we say, cetirizine. We could consider the antihistamine cetirizine, or we could consider hydroxychloroquine, Plaquenil. So is it reasonable for someone to do dutasteride with isotretinoin, with tacrolimus? And if they're not getting better, to consider adding something like cetirizine or Plaquenil? Absolutely it is. Now that's not right for all people. And so that's why each case has to be uniquely discussed with a practitioner. But absolutely, there's a very logical way of thinking about the management of all hair loss conditions. And then if none of these are helpful, then we move down to third line options. but there's a very logical approach to treating FFA. And the treatment for the ear area is the same as for the scalp. And so we don't have to really think all that differently for treating issues around the ear. So in this particular question, you can see that we have options for steroid injections. The patient's already on topical JAKs, topical tofacitinib. There's an option to consider increasing the dose of topical tofacitinib from, if a person's on 2%, to go to 3.2%. A person could consider oral JAK inhibitors, hydroxychloroquine, oral minoxidil, boosting up the dose of dutasteride or isotretinoin if those are well tolerated. Other immunosuppressants like PRP, other immunosuppressants like mycophenolate, as well as PRP. And so lots of options available, all with some evidence behind them to back them up in clinical studies. Question 15. We're still on FFA. I have had FFA for 14 years, and I've been on oral dutasteride for several years. I switched to topical 0.05% dutasteride and 5% minoxidil in April. Is the oral more effective than the topical? I find that I am having hair loss now, and my frontal hairline seems to be receding now. Should I go back on the oral dutasteride? So this is a wonderful question. And again, need a lot more information, but the reason I need more information is because so many things factor into this question. The patient has FFA. She was on oral dutasteride. Now she switched to topical dutasteride, and the hair is worse. So it's so easy here to say, this topical dutasteride made it worse. Jumping to that conclusion, from my perspective at this point in time, would be an error because I don't have enough information. If the patient said, oh, I forgot to mention, I had a serious COVID infection and a serious influenza infection, and I also had 10 out of 10 stress for 7 months in a row, no sleep, and I lost 28 pounds because the stress was never this high in my entire life. Well, this could be responsible for some of the aggravation and flare of the FFA. And so maybe that topical dutasteride is not to blame. So this is why all the information matters. Or if the patient says, I forgot to mention as well, I stopped my Rogaine when the doctor put me on this 0.05% dutasteride minoxidil formulation, this fancy formulation. I gave up my Rogaine. Could that matter? Absolutely, it could. You mean to tell me that the 5% minoxidil in the compounded product might not be as good as the Rogaine? That's right. It might not be. Now, it might be, but it might not be. And so all of these factors matter. And so when I put up this diagram, it's an extremely important diagram because it reminds us that we need all the facts. If we're going to be detectives in hair loss, we need all the facts. We need every single fact. And we can't jump to conclusions too quickly. I went from oral dutasteride to topical and my hair is worse, therefore it's the oral, therefore it's the switch. Could be, but it might not be. So we need to keep an open mind. The principle that's so important here in this question is there's about 2 to 3 forms of oral dutasteride. There's a capsule, and in some countries there's a tablet, a pill, and generally that's about it. And there's several companies that make this capsule. So there's about 2 or 3 forms. There's 20,000 forms of topical dutasteride, at least 20,000. And so there are some that probably work well. But remember, these have not been studied very well. So if you're picking up that topical dutasteride minoxidil from the pharmacy and it comes in this nice bottle and you think, I wonder what clinical study this has been studied in. It probably hasn't. It probably has never, ever, ever been studied. It doesn't mean it might not work, but it's important for you to be aware this has never been studied. So of the 20,000 forms, Form 533, if you're lucky to get it from whatever pharmacy that is, it might work well. But Formula 5,233, it might do nothing. And that is a reality. And so we think when we talk this way that, hey, I'm using topical dutasteride minoxidil. Oh, me too. I'm using topical dutasteride minoxidil. You might be using completely different products. The person on the left might be using a product that works wonderfully. The person on the left might be using a product that works almost nothing. And that's the reality of these compounded products. So we have to be careful. The other thing in this question is the dose of dutasteride differs dramatically around the world. And 0.05% is a pretty low dose. Now, clearly you and your practitioner have discussed this and what's right for you. And so those details I don't know. Those are things you'd have to discuss with your practitioner. But certainly dutasteride doses range topically quite significantly, and it's not uncommon to have doses 5 or 10 times higher than this particular dose, even 15 times higher. And so if you switch from 0.5 milligrams of dutasteride as a pill to topical dutasteride that's too low and not enough gets in the scalp, then the scalp says, where's my dutasteride? The scalp says, you're depriving me of dutasteride. I used to be getting this good dose of dutasteride, and now I'm not. And what happens? The hairline goes back. And so this is a complex situation, and it certainly is suggestive that the switch from oral to topical is contributing, but again, I don't have all the information. So it's something you'd want to review with your practitioner in detail. But yes, topical dutasteride probably is not as good as oral dutasteride in the treatment of FFA. That's probably the reality. Dutasteride is highly reliable, same dose every time, the same degree of application, same number of drops, same method. Are there dutasteride topical formulations out there? Formula 4009 that is just as good as the oral? Probably. But those studies have not been done. We will never have 20,000 topical dutasteride studies, ever. And so it's a challenging field. But that's really important to be aware of. So this is something that's so important for you to review with your practitioner. It could be that your oral dutasteride was better. It could be that the topical dutasteride, the way they make it is not effective. It could be that the dose is too low. Many factors need to be reviewed. Question 16. How does pioglitazone work on a patient with FFA who is already on topical dutasteride and minoxidil? So pioglitazone, which goes by the trade name Actos, is one of the third-line treatments for frontal fibrosing alopecia. So it is an option. It's a type of a diabetes medication that affects a signaling pathway in cells called PPAR gamma. And it certainly is an option. And it can be added. And so if a patient is on, let me see what it was. If a patient is on topical dutasteride and minoxidil, can you add pioglitazone? You can. It's possible. Pioglitazone is a third-line option. And so generally speaking, my preference is to sit back and ask, before we go to third-line options, do we want to discuss any of the first-line options further? Maybe talk about steroid injections or hypoallergenic shampoos or tacrolimus or something up here. And then if we don't want to talk about any of those, or the patient doesn't want them, then second line options. Let's talk about those next. Cetirizine, hydroxychloroquine, doxycycline, topical steroids. And then if we don't want those, then we go to the third line options. So it's a little bit of a jump to go dutasteride, topical dutasteride, minoxidil to pioglitazone. Pioglitazone is a drug that I don't use very often. It's on my list as third line options because it's something that we can at least consider for short periods of time. I'm not a fan of pioglitazone anymore, as I might have been 10 years ago, because pioglitazone increases the risk of bladder cancer. Mostly in people that are using, the 15 or 30 milligram dose for more than a year and a half. But whenever you start a drug, that the minute you start it, you're asking when you're going to stop it. I'm not a fan of that drug because scarring alopecia doesn't have that timeline. Scarring alopecia doesn't have that. It's going to be done in 6 months. It's going to be over in a year. It doesn't have that timeline like a cold or an infection or a flu, where it does a 2 to 4 week course. That's not how scarring alopecia works. So I don't really like to start drugs that as soon as I start, I'm asking, when am I going to stop? And pioglitazone is one of those. There are cases where I will use it for 3 months, 4 months, but it has its series of side effects, and those need to be reviewed with the practitioner. Pioglitazone is certainly not right for everybody. But the concept of adding treatments, can I add pioglitazone to dutasteride and minoxidil? The answer is yes. And the analogy I often use in explaining this is this one. If you imagine that you have a rock or a boulder, and you're trying to push this rock up a hill or a mountain and then down the other side. And imagine that you are starting with one person. One person is going to push this boulder up the hill. And it could be that one person can do it. But if that person says, you know what, I need a lot of help. I can't do this on my own. I need a lot of help. Then who are you going to choose? The person on the left or the person on the right? Going up the mountain, that steep mountain, I'd probably choose this individual than this individual in the dress shoes. I just feel my odds are better. The same with scarring alopecia. If you can win scarring alopecia by using clobetasol lotion 3 times a week, that's all you need. Done. But if you can't, then you have to ask yourself, do I need a lot of help or a little bit of help? Do I need steroid injections or do I need hydroxychloroquine? Do I need something strong or not? Do I need 2 treatments or 3 treatments? And so you can imagine now we've got these 2 people pushing this boulder, and they're doing a good job. And now let's suppose they say, you know what, we just need a little bit of help. We don't need a lot of help, we just need a little bit of help. Do you think this individual can do it? Probably. We wouldn't have called on that individual in the first place, but now we only need a little bit of help, apparently. So there he is. They're winning. They're pushing the boulder up the hill. The same is true with scarring alopecia. At each turn of treatment with scarring alopecia, you have to ask yourself, do I need a little bit of help or a lot of help? And you might say to yourself, well, why wouldn't you just call in a lot of help? Well, when it comes to treatment of scarring alopecia, sometimes that comes with more side effects. So if you call in a lot more help, you're going to start a lot of immunosuppressants, you're going to start a lot of potent drugs, you come with an increased risk of side effects. But you can combine treatments. And so it's not unreasonable to do topical dutasteride with minoxidil with another treatment like pioglitazone. And I've mentioned the reasons why I may or may not do pioglitazone. And so how does it work? You can add them. And so it wouldn't be unreasonable to have a patient on all three. It wouldn't be unreasonable for another patient in another room to be on dutasteride, minoxidil, pimecrolimus, which goes by the trade name Elidil, steroid injections and isotretinoin. That wouldn't be unreasonable. And it wouldn't be unreasonable if the patient in the next room was on dutasteride, minoxidil, pimecrolimus, steroid injections, isotretinoin, hydroxychloroquine, oral cetirizine, and topical tofacitinib. Now, if you're newer to FFA, you might find 1, 2, 3, 4, 5, 6, 7, 8. You have patients on 8 treatments? Yes. Yes. And does it help? Yes. And certainly that reflects to some degree the limitations we have in 2024 with the treatments that we have. But some of these strategies do stop the disease, and some of these strategies do even improve the hair. Now, in some patients, we have simpler protocols. In other patients, we have more complex. It just depends on if we're winning. And so if you see a patient back in 6 months and you realize the boulder is falling back down, we need more help, the scarring alopecia is winning, we call on other treatments to help us. If we see the patient back in 6 months and we realize, wow, you're doing so much better. Inflammation is gone, itching's gone, redness is gone, you even got some improvement in your hair, then we don't have to be thinking about stronger and stronger treatments. And we'd like to keep things as simple as possible. I don't like a patient to be on 8 treatments or 10 treatments. I know it gets tiring for them. I know patients can get treatment fatigue. It's something I think about often. But the reality is these kind of additive strategies can help control the disease in many people. And provided we're monitoring things carefully, provided we're doing things sequentially, it can really help people stop their disease. So let's talk about folliculitis decalvans. Folliculitis decalvans is another scarring alopecia where men and women develop itching and burning in the scalp, often in the crown, but it can be in the front of the scalp, can be further back. They often have pustules. And it often initially appears as a folliculitis. You have a folliculitis. And then you get scarring that develops. You can see this smooth, shiny skin. This is scar tissue, and it looks different than what you might think about in male balding. A little bit of pinkishness or redness to it. That's folliculitis decalvans. So we have a question. Is there any laser recommendations for folliculitis decalvans? Well, this is the treatment protocol for folliculitis decalvans that I use in my clinic. And so first-line treatments include medications like isotretinoin, as well as antibiotics, as well as topical antiseptics and topical antibiotics. Second-line agents include steroid injections with triamcinolone, as well as topical steroids. And you can see these third-line agents include things like dapsone, TNF inhibitors, apremilast, the JAK inhibitors. And here we get into some of the more technologic type treatments. Nd:YAG laser therapy has been reported and now studied, and also photodynamic therapy. So we're gaining an understanding of new methodologies that can be helpful. These aren't explored to the same degree as the first-line agents or even the second-line agents. So if I meet a patient that's just been diagnosed with folliculitis decalvans and they say, what do you think about me going for Nd:YAG laser therapy? My feeling is it's not unreasonable. There's better evidence for us to start with something with more evidence, something in the first-line group. But certainly if a patient says, I don't want any of that. I don't want any of this. I don't want any of this. This is what I want. Then it's not unreasonable. But generally, we like to start with treatments that have the best evidence because it comes with the statistically best chance that the patient will stop their disease. But we're becoming to understand the role of these other therapies, so pretty exciting time. With folliculitis decalvans, once the disease goes into remission, what's the likelihood that it'll flare up again after having a scalp reduction? So a surgery where the scar tissue is removed, stitched up, and you remove the scar. Is a scalp reduction even worth asking for? So the key question here is, what is remission? Because if a disease is truly done, burnt out, this is sleeping, 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 then the chances of success with things like scalp reductions and hair transplants goes up dramatically. The problem in the world is that, 80% of people or more with scarring alopecia who go for surgery are not truly inactive. And that leads to a belief amongst many that, scarring alopecia hair transplants don't always work in scarring alopecia because it flares again. But I would estimate that 80% of people that go for hair transplants in scarring alopecia have active disease. So what is remission? Well, there's a big difference between someone who says, I think it's in remission, and someone who says, I know this is in remission. I know this is sleeping. So what are those criteria? Well, in my opinion, it's these 4. If you really want to prove that you are in remission, your disease is in remission, it's quiet, you're off all medications for 2 years, you have no symptoms, no itching, no burning, no pain, scalp feels good, tap it, hit it, whatever, feels good. The physician who stands over top of your head sees no redness, pustule, scale, crusts, bleeding, looks pretty good. You might see scar from years gone by because it's permanent, but there's no redness and pustules and crust and flaking and dandruff looking stuff. And when the physician touches it, it just doesn't hurt. And when you take a picture and you compare it to another picture taken 2 years ago, they look 100% the same. 100% the same. Yeah, but I don't have a picture from 2 years ago. Nobody took a picture from 2 years ago. Well, guess what? We don't know it's inactive. So let's start today. Let's start the clock today. Yeah, but I want to go for my hair transplant. I understand. I understand. I understand the emotions around this. The thing is that when you have these strict criteria, your chances of success go up dramatically. And, it's really important for me that we increase the odds of success so much. These surgeries are expensive. These surgeries require, a lot of your hard-earned money. They require time off work. They take a lot of your emotion. You put all of your hope into what will come of this. So we want to put all those eggs in the basket at the right time. And so when you look at these criteria, if you don't meet these criteria, I know it feels awful and you feel disappointed and frustrated and sad, and I know that. But the reality is this has to be quiet for 2 years. And not just whispering, this has to be quiet. Quiet, quiet, quiet. No itching, no burning, no pain, no redness, no shedding, no change. And those are strict criteria, but if you meet these criteria, your chances of success are really high. Doesn't mean it's perfect. Doesn't mean your surgery is going to be beautiful, but it increases your chance of success dramatically. If you don't meet these criteria, your chance of flare is high. Higher. Still not 100%, but it's higher. Question 19. We see scarring alopecia with folliculitis decalvans. My understanding is that permanent hair loss and damage to the hair follicle occurs. What is the success rate of a hair transplant and maintaining a functional follicle? So again, it comes down to 2 questions. If you're going to do a hair transplant in folliculitis decalvans, do you meet all these 4 criteria? Are you on any medications, by the way? Yes, I take clobetasol once a week. Okay, we got a problem. Why do you take clobetasol once a week? Oh, because it keeps the redness down. By definition, it's active. If you require clobetasol to keep the redness down, you're telling me that without clobetasol, your immune system acts up. A hair transplant is an incredibly immune activating surgery. So you have to be off medications. No redness, no pustules, no flaking, no itching, burning, or pain, and no change in that photo. Then the second question is, how thick is the scarring? So if you say to me, I had folliculitis decalvans 10 years ago, it's been quiet for 10 years. Here's all my pictures, 2010, 2015, 2020. Look at them. Look at them. All the same. I look the same. That's great. No itching, no burning or pain, no redness. That's fantastic. The second question is, how thick is the scarring? And I use this analogy to help understand this. Imagine we're going to plant this tree. Imagine we're going to plant it into this beautiful soil. You can imagine this tree is probably going to take just fine. It's going to transplant just fine. Look at how rich this soil is. Now our goal is to plant the tree in this cement highway, cement roadway. We know that it's not going to take. Why? Because there's just not enough nutrients and not enough supply of what it needs. Same is true with scalp. Sometimes some patients with folliculitis decalvans have tremendous amount of scar tissue. And that differs from Lichen Planopilaris. Lichen Planopilaris can be very scarry, but there tends to be less scar tissue than folliculitis decalvans. So that means that successes are a little bit lower with folliculitis decalvans. It still can be very good. But this is the typical scar tissue that exists in scarring alopecia. And sometimes when you poke that with a needle, it bleeds. That means there's lots of blood vessels there. That's a good sign. Sometimes some scar tissue is so thick that when you poke it with a needle, it doesn't bleed because it's so thick. It's this thick scar tissue. And hairs don't grow well in that type of scar tissue. So much more dramatic scarring in folliculitis decalvans. Doesn't mean can't be successes, because there can. But when you put those strict rules to work, that's when you get these happy stories, at least a greater chance of these happy stories. And when you bypass these rules, that's where you increase your odds of having a story such as, I went for a hair transplant. It looked good after a few months and then kind of just didn't take. Or it looked good for a year or two, and then I lost all my grafts, or something else. Now, even with active scarring alopecia, there are some patients that do great. We don't understand why that is. But there are some patients that, because I've followed them over the years, patients that say, I hear what you're saying. I appreciate what you're saying. I appreciate all your advice. I feel like I got to do this now. I got one chance, and I respect what you say. Thanks for your advice, but I'm doing it. That's okay. I want people to do what's right for them with my advice. And there has been an occasional success story where a patient has active disease and they have a hair transplant and they have some pretty nice outcomes. Now, is that outcome going to stay for 5-10 years? I don't know. But, after a year or two, it's looking pretty nice. So there are some exceptions. Question 20. I see some of the recommendations for steroid injections in folliculitis decalvans up to 20 milligrams. Is it administered only to affected areas, or do you inject at other sites? So generally in the affected areas. So I would inject here, 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 here. But if there's enough medication, and this would be considered a fairly small area, then I'm going to put into the surrounding area to tell the scalp and the immune system, don't even think about attacking these hairs. You've been attacking these hairs, but don't even think about going after these ones. So if I have enough steroid, I will put it in the surrounding areas as well. But my main focus is on these hairs, and I don't put any in the middle. Those hairs are permanently destroyed and not recoverable. I was recently diagnosed with Demodex blepharitis and had Folliculitis Decalvans for 10 years. How often do you see Demodex mimic Folliculitis Decalvans, and how do you treat it? Really, really unique question. So the answer is rarely. Rarely do we see Demodex as the cause or contributor to Folliculitis Decalvans, but it's not impossible. So there's some really nice reviews online. They're free. They can give you some understanding about how to treat Demodex blepharitis of the eye. And there's some new emerging therapies. But blepharitis is a condition characterized by inflammation of the eyelid margins. And it's super common in human beings. 20% of people over 40 have blepharitis. And Demodex, or this infestation with this mite, accounts for 60% of blepharitis. And so Demodex blepharitis is super common. Demodex of the scalp causing a problem is rare, but not impossible. So when you have health issues related to Demodex, this mite, we call it demodicosis. And this is an asymptomatic inhabitant of human hair follicles. So one of the features about being on this planet is we share our environment with other things, like it or not. We share with bacteria. We've got trillions of bacteria and viruses and fungi in our gut. And we've got these on our skin, we've got these in our scalp, and we got these mites. And when you look under the microscope at these mites, or you see these up-close magnifications, you think, I can't believe I would have that on my scalp, but we do. And often these cause absolutely no problem. And in fact, Demodex mites approach about 100% in elderly people. But that doesn't mean they necessarily cause a problem because they're in such low density. But when they're found in high numbers, or they're buried in the skin deeper, then we have a problem. And you can identify Demodex under the microscope. So Demodex is common. 100% of older people have it. What about Folliculitis Decalvans? Folliculitis Decalvans, the scarring alopecia, is rare. My estimate, about 1 in 15,000. And rarely Demodex can cause a folliculitis, so it can inflame hair follicles to the point where they're red, itchy, scaly, burning. You can get bleeding, and it can very much mimic Folliculitis Decalvans. This is a patient with Demodex folliculitis. You can sometimes see Demodex in scalp biopsies of patients with hair loss, and in most cases, the Demodex is not causing a problem. A true Demodex folliculitis is characterized by hair loss, redness, scaling, and pustules. So this is the Demodex folliculitis. This patient is itchy, burning. They have pustules and bleeding and scaling and redness. And when you look at this slide, you think, this is like, I don't know, psoriasis, seborrheic dermatitis, folliculitis decalvans. I don't know, so many things. Very common in Demodex folliculitis. And when the pathologist sees Demodex in high numbers under the microscope, when you do a biopsy, they may be thinking about Demodex folliculitis. But can Demodex folliculitis mimic Folliculitis decalvans? It can, but it's rare. Is it possible that a person has Demodex folliculitis and they've been misdiagnosed for Folliculitis decalvans? That would be uncommon because of the pattern of scarring that we get, and we would expect the pathologist to identify the Demodex in the scalp biopsy. But if we're worried about Demodex in the hair and we think there's a Demodex folliculitis, there are treatments that can be discussed, including ivermectin, either topically or orally, but sometimes orally, 2 doses apart, 12 to 15 milligrams. a week or so apart, depending on the patient's weight. And sometimes we use oral metronidazole as well. And Demodex is really a great mimicker. Patients with Demodex can have a rosacea-like presentation, in addition to this red scalp-like presentation. Metronidazole is possible as a treatment. Ivermectin, as I mentioned, but also doxycycline can be used in some cases, and isotretinoin. Never together, those two treatments, but you can see that there are some confusion that exists when you think it's a scarring alopecia and you treat with doxycycline and they get better, and you think, oh, that proves it's a scarring alopecia. Well, sometimes Demodex gets better with those treatments as well. And do read that review article if you're interested in the treatments for blepharitis. There's lots of treatments that an ophthalmologist or an optometrist will recommend, including baby shampoo on the eyelids. Anything that disrupts the mites can really help. Certain types of ointments. And this lotilaner ophthalmology ointment has just been approved as of last year as an FDA-approved treatment for Demodex. And it impairs the nervous system of the mite and is a new treatment. But we can use ivermectin cream, and tea tree oil type products have been used for a long time in the treatment of Demodex blepharitis. CCCA is central centrifugal cicatricial alopecia, a common scarring alopecia in Black women, often with hair loss in the center of the scalp. And the question that's been asked is, do you believe that JAK inhibitors are the most effective treatment for CCCA? And that answer is no. This is my treatment approach to CCCA. Doxycycline, steroid injections, and minoxidil, as well as gentle hair care, are the most effective treatments for CCCA. There are other fascinating treatments which may help: topical metformin, JAK inhibitors. These are interesting, but they're second-line options. You can see JAK inhibitors down here. So when I see a patient with CCCA, I would much rather them start steroid injections and minoxidil any day than jump on a JAK inhibitor. But there is evidence emerging that these treatments could be helpful. But in terms of the big picture and the degree of evidence that we have, I think the evidence is much better for the agents that you see here in the first line box. LPP. LPP is a scarring alopecia that often affects the central scalp. It's a little more common than FFA. LPP's, probably 1 in 2,000. Could be 1 in 1,000 in people over 70, but more common than FFA. And we have a question that says, do you believe ixekizumab can cure LPP, as per the paper below, with outstanding results? And so the answer is no. We don't have a cure for LPP yet. A cure means you administer a treatment and the disease vanishes, never to come back. That doesn't exist at the present time for LPP, but the hope is that one day it could. Ixekizumab is a treatment that targets a specific protein and pathway called the IL-17 pathway. But these are third-line options for LPP. First-line options would include steroid injections, topical steroids, tetracyclines like doxycycline, sarecycline, as well as plaquenil, hydroxychloroquine. And then a whole bunch of second-line options, including antihistamines like cetirizine, cyclosporin, methotrexate, mycophenolate. These have much better evidence than a single case report of ixekizumab. So I think it's certainly exciting that we have these new agents, but very limited evidence and not a cure. The last question or two says, I likely have LPP. I never had a biopsy. I'm currently undergoing various treatments for the last 2 years. My symptoms, itchiness and tenderness, have improved, but they're still present. I have extremely dry, curly hair, and I've struggled to find out what hair products, including shampoo and conditioner, I can use that's safe for my condition and won't make it worse. Do you have any recommendations? So again, Story is really important. The story is so important here because what is needed is for me to understand the patient's hair history in detail. And I'll give you two examples. First, I've made a note to myself. This comment, my symptoms, itchiness and scalp tenderness have improved but are still present, suggests that this condition is still active. And so as a person is having dry, curly hair, struggling to find out what could work, it could be that treating the LPP to stop the activity could help some of these hair issues in terms of the dryness and how the hair feels. But there's two types of patients with LPP when it comes to textural issues. The first is a patient that can use whatever they want. So these discussions about what shampoos, what conditioner should I use are absolutely irrelevant. So the first type of patient can use any type of hair products. Different products might affect how your hair smells or the shine or the appearance, but they're not going to cause harm. So use what you like. That's one type of patient. The second type of patient is probably more common, but they have to be careful with their products. Some have allergy to certain ingredients or irritation from certain ingredients, including fragrances and preservatives, sometimes colorants, dyes. And so it's important to figure out with a careful history that your practitioner will do to figure out which type of patient you are. There are some patients with LPP that can use whatever product they want. And any big discussion about what conditioner should I buy, what shampoo should I buy, are of no relevance. Buy what you like. And you and your practitioner can figure out which of the two categories you fall into. But certainly when there is active scarring alopecia, we need to get it quiet, because by improving the activity of the scarring alopecia or making it more quiet, we can sometimes improve those issues. Common things being common, some irritation and dryness and textural things can be as simple as seborrheic dermatitis. So considering discussing with your practitioners about integrating anti-dandruff ingredients into a routine can be very helpful. When necessary, sometimes what we do when we want to test these hypotheses, is there truly something in a shampoo that's bothersome? We will switch to a hypoallergenic shampoo. And some of these products online, like Scene, fragrance-free shampoo, and Vanicream Free and Clear, and Vanicream Free and Clear Anti-Dandruff, these are available in North America. They're devoid of fragrance. They're devoid of preservatives. They're devoid of cocamidal propylbetaine, which is a surfactant, which makes the shampoo sud up. We love when our shampoo lathers up, so we have this big lather all around our head. When you get rid of those, sometimes scalp issues improve. And the thing that's nice about the Vanicream Free and Clear line is they have the anti-dandruff line as well, so we can treat the seborrheic dermatitis at the same time. I think this is the last question. Chemotherapy-induced alopecia. Thank you for this question. What effect will chemotherapy drugs have on scarring alopecia? Are there safer chemotherapy drugs to receive than others, or do all drugs destroy the hair follicle? The thing that's important with this question is there's hundreds of cancer treatments. There's hundreds and hundreds of cancer treatments. So we've got dozens upon 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 dozens of drugs. And the drugs used to treat brain cancer are different than breast cancer, is different than stomach cancer, is different than skin cancer, is different than breast cancer, is different than colon cancer. There is overlap, of course. There's hundreds and hundreds and hundreds and hundreds of drugs. And they affect the hair in a different way. About 60% of chemotherapy drugs cause hair loss immediately. But there's two types of hair loss. One is a hair loss that occurs immediately after you receive a chemotherapeutic within the first 3 weeks. And then it comes back within 3 or 4 months, 5 months. That second type is a type of hair loss where a patient loses hair and then they don't regain it. They don't regain the density they once had, and that's called persistent chemotherapy-induced alopecia. Chemotherapeutic agents destroy hair follicle stem cells, at least some of them. For example, some of the drugs used in breast cancer, like docetaxel. Scarring alopecia destroys hair follicle stem cells as well, destroys the seeds that can make a new hair follicle. So both chemotherapy drugs and scarring alopecia destroy hair follicle stem cells. And so you can imagine when you have chemotherapy given to a patient who has scarring alopecia, you have two agents that are working to destroy hair follicle stem cells. And so the risk of permanent hair loss seems to be higher in patients with scarring alopecia receiving chemotherapy than in non-scarring alopecia. But remember, not all drugs cause hair loss, and not all drugs cause permanent hair loss. But cancer treatments are chosen according to the cancer. So the question asks, what cancer drugs are safer? It's not always possible to go down a list of drugs that are least likely to cause hair loss and say, I want that. For example, let's say drug A rarely causes hair loss, and drug B often causes hair loss as a cancer drug. And let's take as in the theoretical example, breast cancer. Drug A rarely causes hair loss, but it has no effect on this cancer, so we can't use it in breast cancer. Drug B often causes hair loss, and it's one of the #1 drugs for breast cancer. And so sometimes there are challenges in the treatments that we have, and we have to go according to the protocols that have been studied for each cancer. And for example, in breast cancer, some of the medications used in treating breast cancer are known to cause hair loss, and sometimes cause a persistent hair loss, but not all the time. And we're becoming better at treating that type of hair loss as well. So that brings us to an end of the 2024 Hair Loss Awareness Month. I want to thank everyone for joining me and for sending in these incredible questions. These really are 24 really wonderful questions that you don't see asked many places, and to have this opportunity to discuss such intriguing questions and have an opportunity for you to share these questions and have these stay as a permanent position somewhere that can be accessed by other people trying to find this information is such a wonderful resource. So thank you for sending in these questions. I really appreciate it. And stay tuned for other webinars that come up throughout the year. I enjoy doing these very much, and I appreciate all your interest and attention in joining me for these webinars. And we'll post this on the Donovan Medical YouTube channel. And you can look for some updates for that in the weeks ahead. Generally, we post it within the week of the presentation, but it'll be posted in the upcoming weeks for you to refer to at your leisure in the future. But thanks so much for sending in these questions. I wish you a great rest of the summer for those in the Northern Hemisphere, and look forward to seeing you again the next time. Thanks again, everyone. Enjoy the rest of your day or evening. Bye-bye.